Hi, I'm Dr. Rashmi Roy, thyroid surgeon here at the Hospital for Endocrine Surgery and director of Thyroid Surgical Services. So today we are doing a live question session for thyroid cancer because it is Thyroid Cancer Awareness Month, so it's a perfect time to do it. If you guys have any questions, just put them in the comments and I'm happy to answer them. And we'll just get started with our first questions. So the first question for this session is, I was told I have a suspicious nodule. Does this mean I have cancer? So not necessarily. So thyroid nodules, when they're biopsied, they are categorized into different categories. And those categories are called Bethesda categories, and those categories are categories 1 through 6. So category 1 is non-diagnostic. Category 6 is a clear thyroid cancer. And then in between, you have your benign biopsies and then this broad suspicious category. So 1 is non-diagnostic, 2 is benign, 6 is cancer. And then in between, category 3, 4, and 5 is this broad suspicious category. And as you increase categories from category 3 to 4 to 5, your risk for this nodule being thyroid cancer increases. So Bethesda category 3 has about a 10% risk of being thyroid cancer. Bethesda category 4 has about a 50%, and category 5 has a 75% risk for thyroid cancer. So a suspicious nodule just means you have some risk of this nodule being a thyroid cancer, and surgery is recommended for diagnostic purposes and for cure purposes. So if you have a suspicious nodule, you should contact us because you will need surgery. Next question. I don't want to be on meds for the rest of my life. Can you help me understand how a partial thyroidectomy works? Who is a good candidate, and if this would guarantee no thyroid meds? So here at the Hospital for Endocrine Surgery, we always want to try to preserve half of your thyroid gland if we can. So preserving half the thyroid gland means that you will have natural thyroid hormone. And obviously, it's a smaller surgery if we're just taking out half your thyroid versus your whole thyroid. We think having natural thyroid hormone is better for your wellness. And the major thing that affects you is that maybe you won't need thyroid medication. So 50% of patients with half their thyroid do not need thyroid medication. The other 50% need a supplement. So, maybe worst case scenario, the majority of your thyroid hormone is coming naturally. You just need a little bit of a supplement through the thyroid hormone replacement pill to boost you back into that normal range. So, you're a good candidate if the half of your thyroid gland has no thyroid nodules, or if they're just small thyroid nodules and benign, if it's just Hashimoto's and you're doing well on medication already. So these are reasons that we would want to save half of your thyroid gland. Obviously, if you have suspicious nodules on both sides of your thyroid gland, we don't want to save a suspicious nodule that's going to set you up for a second operation. We don't want to do that. So, the short answer, 50% of patients with half their thyroid don't need medication. And if you have no nodules or small benign appearing nodules on half your thyroid, we want to save it. Next question. Can suspicious nodules disappear without treatment? So no. There's nothing that you can do to make suspicious nodules disappear. There is no, iodine treatment or creams. I had a patient the other day that told me she was putting iodine cream on her neck to try to get rid of her thyroid nodules. That doesn't work. Turmeric, all of these different alternative pathways that may provide other benefits are not going to make your suspicious nodules disappear. So you do need, like I said, at least half your thyroid removed for diagnosis or cure if you do have a suspicious nodule. Next question. My endo recommended I see an ENT surgeon for my thyroid cancer, but I have watched many of your videos where you emphasize the importance of seeing a thyroid-specific surgeon. Does an ENT surgeon qualify? So they can, absolutely. There's different pathways to be a thyroid-specific surgeon. One pathway is to be an ENT-trained surgeon, and the other pathway is to be a general surgeon who has a specific fellowship training in endocrine surgery. So for instance, so I'm a general surgeon who did specific endocrine surgery fellowship training and specialized in just thyroid surgery. Dr. Clayman is an ENT surgeon who specialized in thyroid surgery. So there's two ways to get to the same place, but the most important thing is to ask and interview your surgeon, how many thyroid surgeries specifically do you do? So an expert thyroid surgeon, the literature says that they should do over 100 thyroid surgeries a year. I don't think that's enough. So I do 600 thyroid surgeries a year, probably more than anyone in the country. So make sure they do a lot of thyroid surgery. Ask them what their complication rate is, what's their nerve injury rate, what's their injury rate to parathyroid glands, what is their recurrence rate. So these are all things that you should know. This person is going to be operating on your neck, so don't feel bad about interviewing your surgeon. You have every right to do that. And an accomplished surgeon who is an expert will have no trouble answering your questions. So if there's any hesitation on a surgeon answering those questions, that should be a little bit of a red flag as well. Next question. I have a large goiter and am scared to death to have surgery. I was told goiters are not usually cancerous, so it's okay to live with it if I choose to. Is this correct? What would you recommend? Okay, so this is kind of a multi-part question. So number one, I see patients all the time that have this goiter for 15 years, 20 years, and then finally they see me and their goiter is sticking out of their neck. I mean, it's all that you can see. And then I ask them, why haven't you had this goiter removed in the past 15 or 20 years? And they tell me that their doctor told them, if it's not bothering me, to not have the surgery. So to me, I think this is a little bit crazy, because why are we letting something grow so much in your neck so it's so visible, and it can cause symptoms. It obviously makes the surgery difficult once it's so big, growing down into your chest. And so if you have a large goiter, don't wait and let it grow over years just because you may not be symptomatic. So that's the first thing. As pertaining to thyroid cancer and goiters, so statistically speaking, and mostly, thyroid goiters are benign. However, that's not always the case. So a lot of times multinodular goiters have large nodules. And so you can get a biopsy of some of these nodules and you can have benign biopsies. But when a nodule is very big, it's like putting a needle into an apple. So you're not getting a good representation of the whole thing. So you could have a benign biopsy here, but here you're hiding a thyroid cancer. So goiters can certainly be cancerous. Statistically speaking, like I said, they're usually benign, but they certainly can be cancerous. So another reason to not just watch and wait your thyroid goiter enlarging. If you have one, you should be seeing an expert surgeon. You should have it evaluated by a thyroid specialist. And most likely you're going to need surgery. And if you do have thyroid cancer in a goiter, it will be cured by the surgery if it's done by an expert thyroid surgeon. Next question. How do you determine if the cancer has spread to lymph nodes? So this is part of our expert evaluation that we do here for every single patient. Even if you come here with a benign nodule, you're still getting the same evaluation of your lymph nodes with us during your evaluation. So there's two ways to determine if the cancer has spread to your lymph nodes. The first way is with our high resolution ultrasound, the thyroid ultrasound is not only of your thyroid, but it is of every level of lymph nodes in your neck. So when we talk about thyroid cancer and lymph node spread, there are anatomical locations. They're called level 2 through level 7. So the sides of the neck and the center of the neck. So we're looking at all of the lymph nodes in your neck with our ultrasound. Like I said, even if you have a benign nodule. So that's the first way that you evaluate lymph nodes, is with a high resolution ultrasound. It's called neck mapping, where all the lymph nodes are looked at. And the second way that we evaluate lymph nodes, and that's very unique and special to our center here at the Hospital for Endocrine Surgery, is that we remove the lymph nodes underneath your thyroid gland during the operation, and we test them while you're asleep. So we know exactly what's going on with your lymph nodes so that we can make sure when you wake up from surgery, you're cured of your thyroid cancer. You do not need a second surgery. A lot of centers, they will do an operation and then they'll get final pathology and then they say you need to come back, several months later to take out the other half of your thyroid gland. That's not how we do it. We designed the center to make sure that you are cured of your surgery when you wake up, and that is by us pathologically looking at your lymph nodes real time. So we determine if thyroid cancer is spread to lymph nodes preoperatively by ultrasound and intraoperatively with pathology during your surgery. Oh, I should also say, during the ultrasound, if we see a lymph node that is suspicious, then we do a biopsy right then and there. So if it looks suspicious on ultrasound, we biopsy it, and we have real-time pathology again with us in the evaluation center that will let us know if that lymph node has thyroid cancer in it. And if it does, then it significantly changes the operation. So ultrasound and biopsy of the lymph node preoperatively, and then pathology inside the operating room. Okay, next question. Are there any alternatives to radioactive iodine? So this is a little bit of a controversial question. So radioactive iodine, we know, works really well in children. We do not know, candidly, how well it works in older adults. So radioactive iodine is still recommended, even though we don't know how it works, because it's really the only other trick that we have with thyroid cancer after surgical resection. So there are patients that don't want radioactive iodine treatment, and that's okay. There's really no other alternative to radioactive iodine treatment other than very close monitoring with ultrasound and blood work. So, we don't do a surgery that's dependent on radioactive iodine, meaning that your surgery should be curative and the radioactive iodine is given for any microscopic cells that are left behind that we can't see. So we're not leaving tissue behind and saying, the radioactive iodine treatment is going to take care of it. All of the thyroid or the gross disease will be removed. So if you don't want radioactive iodine and you and your endocrinologist and your surgeon feel comfortable with that, then you just need to be monitored closely with ultrasound and blood work. And then if anything, obviously, pops up on either one of those monitoring devices, then, further steps are taken. So it's either radioactive iodine treatment or monitoring. Next question. Is radiofrequency ablation, or RFA, a good option for small suspicious nodules? So no. So radiofrequency ablation is indicated for benign nodules. So if you have a nodule that is, 2.5 centimeters, 3.5 centimeters, and you have had 2 benign biopsies, so we know it's a benign nodule and it's causing you symptoms, you are a great candidate for radiofrequency ablation. And so this is a non-surgical option to help shrink the nodule so that your symptoms will be resolved. But if you have a suspicious nodule, if you have a thyroid cancer, this should not be ablated with radiofrequency ablation. Surgery is still the best option for suspicious nodules, even if they're small. Next question. I have suspected thyroid cancer and need surgery. However, I have a young child and am still breastfeeding. How will this affect that? Should I wait until I am done with breastfeeding? So, we get these questions a lot with pregnant women, women who are breastfeeding. So thyroid cancer, for the most part, when we're talking about the most common papillary thyroid cancer, is a very slow growing process. So I'll take this question a step back and then I'll address this question directly. So if I had a patient who we diagnosed with thyroid cancer, and then they called me the next day and they told me that they were pregnant, I would tell them to deliver the baby, and we'll operate on you afterwards. So that also puts things into perspective. This is not an urgent operation. We're not rushing you to the operating room. We want you to have a healthy pregnancy. And then as far as, for directly this question, as far as breastfeeding, we want you to have that 3 months after you have the baby for bonding with the baby. So breastfeeding your baby 3 months after surgery, after you've had that bonding time, then yeah, absolutely. Let's go ahead and take care of the thyroid cancer. And so the American Association of Anesthesiologists, they actually don't even recommend a pump and dump after surgery. But, for the most part, we would we'll feel a little bit more comfortable, even though, the guidelines say you don't have to. So after general anesthesia, just do one pump and dump, and then you'll be able to breastfeed the baby later that afternoon. So, obviously just store up your breast milk, and then after surgery, after you're recovered, later that afternoon, that evening, you'll be able to breastfeed, and it won't be an issue. Next question. My endocrinologist told me that papillary thyroid cancer is slow growing and that it's okay to wait and monitor it for another 6 months to a year. Is this true? Is there any rush to get it out? So this is actually very well placed. So it's just like I said, if there's a reason, that some patients I talk to, and they say, oh, we have this big, huge family reunion trip, this cruise that, we've planned, and do I need to come in and, for you to operate on me right away? Or, no, no one's rushing to the operating room for papillary thyroid cancer. I don't think you should be watching and waiting a thyroid cancer. So you don't want to take it to the other extreme where you have a thyroid cancer and you're watching it for years. I mean, that's not what I'm trying to say either. It should be scheduled when it's appropriate for you and fits into your calendar. So, there's no rush to it, but I wouldn't monitor a thyroid cancer. What are we waiting for, right? Are we waiting for you to have symptoms? Are we waiting for the cancer to invade the nerve and for you to have hoarseness? So I always say, with thyroid cancer, usually patients actually don't have symptoms, but you don't want to wait till you have symptoms, because patients that have thyroid cancer that get symptoms, these are life-altering symptoms. I mean, this is called, permanent hoarseness, difficulty swallowing, difficulty eating. So don't monitor your thyroid cancer. You do need surgery, but there's no rush to do it. Okay. Next question. How soon do you schedule surgery after a consult? So this is obviously pertaining to our center and how we do our evaluations and surgery scheduling. So for instance, if you're from out of state, I'll give you a phone call. We'll go over all of your all of your records, your ultrasound, your biopsy report, CT scans, whatever you've had done. And then I'll let you know kind of what the surgical plan would be. And then I'll give you a phone number that you need to call to get things scheduled. We're booking about 3 to 4 weeks out from surgery. So if I call you on the phone, you'll probably get in to see us, 3 to 4 weeks later for your same day evaluation and surgery. If you're in the state of Florida, we'll likely have you come in, do an evaluation in person. And then your surgery will be scheduled 2 or 3 weeks later. That's usually the case unless obviously you're very far away from us in the Panhandle or Miami or, something like that. But surgery is usually scheduled about 3 to 4 weeks out from your conversation with one of the surgeons. Next question. If I was just told that I might have thyroid cancer, should I stick with my endocrinologist or see an oncologist? So this is a great question. Definitely your endocrinologist. You do not need an oncologist. For the most part, oncologists actually don't know that much about thyroid cancer. Oncologists are great for other types of thyroid cancer, for other types of cancer. But for thyroid cancer, an endocrinologist who specializes in thyroid is the person that you need for follow-up follow-up treatment and follow-up monitoring. So, your thyroid cancer, once it's diagnosed, once it's surgically removed by an expert thyroid surgeon, our recommendation is a baseline ultrasound at 6 months with blood work with your endocrinologist, and then yearly thereafter, ultrasound and blood work with an endocrinologist. So you don't need to, search around for an oncologist. You just need to make sure that you have a good endocrinologist who knows how to handle thyroid cancer and has experience in that. Next question. I've heard it's not possible to confirm cancer until after surgery, but others say they had a confirmed cancer diagnosis before surgery. Which is correct? Well, they're both correct. So I'll tell you that 50% of the time that I go into the operating room, we don't diagnose thyroid cancer until after the surgery. So if you guys were tuned in earlier, I was talking about different biopsy results. So, an indication for thyroid surgery is if you have a suspicious nodule on biopsy. So we don't know if you have a thyroid cancer many times before we go to the operating room, but we're going to do a curative operation to cure any potential thyroid cancer. We can go in and it's suspicious and the final pathology is benign. We can go in, it's suspicious and the final pathology is cancer. But either way, the process is going to be cured. Obviously, if you come in and you had a biopsy and it's a Bethesda 6, it's clearly a malignant cancer. We know it's a thyroid cancer. But if you come in with a Bethesda category 3, 4, or 5, we don't know yet. But we're going to do an operation that's curative of any potential thyroid cancer, so that when we get the pathology, we know that you don't need anything else done. Next question. How can I have thyroid cancer with normal blood work? So I get this question all the time. People don't understand how they can go for their annual blood work and have normal thyroid function, and then all of a sudden be diagnosed with thyroid cancer. And it's completely understandable that the patients don't understand because it's not really explained to you. And the fact of the matter is that having a nodule, that's thyroid cancer, has no effect on how your thyroid is functioning. So thyroid cancer and thyroid function are two different things. So the majority of patients with thyroid cancer will have completely normal blood work. So it is a surprise. And so there's no way for you to know. There's no blood marker or anything like that on routine checkups that will give you a red flag that tells you that you have a thyroid cancer. The only way to know if you have a thyroid cancer is if you have symptoms, or if you are found to have a thyroid nodule by someone feeling your neck, or if you're found to have a thyroid nodule by another scan, like a carotid ultrasound or a CAT scan after a motor vehicle accident, or some other scan that you have had done that identifies a thyroid nodule that then prompts you to get a dedicated thyroid ultrasound and a biopsy. So don't also fool yourself that there's no way you can have thyroid cancer if you have normal blood work, because they just don't go hand in hand. Okay. More questions. I have a non-toxic multinodular goiter and want to come see you from out of state. Do you need all of my prior test results? How long will I be required to stay in Tampa? So what we would need is an ultrasound. That's the most important thing, is an ultrasound. If you've had any previous biopsies, if this is a large goiter that's going down into your chest, that you can see on my YouTube channel, I want to make sure that I'll be able to take it out. So if you've had a CAT scan, I want you to send me a CD of the CAT scan so that I can review it before you make the trip here. But for the most part, just an ultrasound, and if you've had any biopsy reports, that's the most important thing that we need. Obviously, if you have, a cardiac history, heart history, lung history, or you have other medical problems, we want records from those doctors just to make sure that you're safe for surgery. But that's usually not the case. Usually, most of you are pretty healthy, so it's just an ultrasound and biopsy reports. And I'll look at that, before we actually have a phone call, and we talk about everything. So I'll review your records and I'll go over all that with you and tell you what I think. And then you would come in, we would do your evaluation in the morning, which is an ultrasound, any biopsies that we need to do, any CAT scans that we need to do. We'll talk about the results in person. Your surgery will be that afternoon or the following day, just depending on how you want to schedule it. If only half of your thyroid is removed, you actually go to the hotel the same day. If the whole thyroid is removed, then I will ask you to spend the night in the hospital. But either way, we want you to spend 2 days at a nearby hotel before you fly back home or drive back home. We actually have partnerships with 4 hotels that we have discounts with. We have a shuttle service that goes from the hotel to the hospital. We try to make this as convenient for you as we can. And then all of our hotels actually have shuttle services from the airport to the hotel. So you don't even need to rent a car. We've taken care of all of that for you. So ultrasound and biopsy records, you'll either go to the hotel the same day or spend 1 night with us, depending on the extent of your surgery. And then 2 days after surgery at one of our hotels or an Airbnb or whatever you want to do before you fly back home. Next question. Can you tell through ultrasound what type of thyroid cancer it might be? Does papillary thyroid cancer appear different than anaplastic? Okay, so this is kind of a 2-part question. So there are very typical things that we see with the papillary thyroid cancer. Papillary thyroid cancer has what we call microcalcifications within it. So when we see thyroid nodules with microcalcifications, irregular borders, this is we're able to tell that that's most likely papillary thyroid cancer. Follicular thyroid cancers or Hürthle cell cancers, they have much more of a vascular appearance to it on ultrasound. So vascular meaning blood flow. Nodules actually shouldn't have any blood flow. So nodules that are big, that kind of light up on the ultrasound with red flow to it, that indicates a vascular tumor. Those kind of give us a red flag of a Hürthle cell cancer or a follicular thyroid cancer. And for those patients, we'll actually do a special overnight pathology. We designed our center so we're able to do kind of stat pathology overnight, so we know exactly what you have the next day and we can act accordingly if we need to. So we have an idea when we see the ultrasound of what kind of a cancer this is. Obviously, the microscope is the determining factor, but we certainly have an idea of what type of cancer you may have. Anaplastic thyroid cancer, guys. So when you have anaplastic thyroid cancer. So a lot of patients that I talk to on the phone, they find out they have a nodule that's suspicious for thyroid cancer and they're freaking out. I need to come see you. How do you know if this is an anaplastic thyroid cancer? So anaplastic thyroid cancer is a rapidly growing mass, meaning, a couple weeks afterwards, you're seeing that this mass is extensively grown. You're having symptoms. It's a hard, fixed mass. We just know when we see it. And then on ultrasound, it's just an ugly tumor. It invades the surrounding structures. There's no clear planes. It has very irregular borders. It can even have what we call necrosis, where there's dead portions of the tumor. So again, it appears very different from just your standard papillary thyroid cancer or even your follicular thyroid cancer. So don't panic. Don't kind of go down that rabbit hole that if you have a thyroid cancer, that you have anaplastic thyroid cancer. It is so rare is the other thing to remember. Papillary thyroid cancer is the most common one. And if you have a thyroid cancer, it's most likely papillary. And they look very different. Okay. So last question. My mom had thyroid cancer. Does this mean I'm more likely to get it myself? Is there anything like the BRCA gene that I should be checked for? So we hear this a lot also. So there's a couple things that we know are risk factors for thyroid cancer. One is a family history, and 2 is exposure to radiation, external beam radiation, or even patients that had exposure to, radiation events like the Chernobyl event. But for the most part, I will mention this, Most patients, and I'll tell you 90 to 95% of patients, maybe even more than that I see with thyroid cancer have neither one of those, don't have family history or radiation exposure. So it's just kind of out of the blue. We actually don't know what specifically causes thyroid cancer yet. We think that it is estrogen related because women get thyroid cancer 3 times more likely than men. So we think it's estrogen related, but we don't have a causative link yet. So, you know, when we talk about family history of thyroid cancer, we're talking like through generations. You know, your grandmother, your aunt, your mom, your sister. I mean, those are what we call kindreds of families that have thyroid cancer. If your mom had thyroid cancer, you know, we're definitely a little bit, you know, on edge because, you know, if you have a thyroid nodule, you just want to make sure you're taking the correct actions, that you're getting it monitored, you're getting it biopsied. But I wouldn't go screening your whole family or anything like that just because one member had thyroid cancer. It doesn't mean just because your mom had it, you're more likely to get it. I would keep it in the back of your head so that if you do feel anything or if you do have a thyroid nodule, to just be on top of it, get an ultrasound, get a biopsy, things like that. There's no gene for papillary thyroid cancer. There's a genetic thyroid cancer called medullary thyroid cancer. That definitely requires genetic testing. It's called the RET gene, R-E-T. So if someone in your family has medullary thyroid cancer and they have a RET positive medullary thyroid cancer, then all immediate families need to be tested because there's a 50% chance that you might have it. So I'm talking parents, sisters, brothers, children. So that definitely needs to be tested. But for standard papillary thyroid cancer, no, you don't need to. Well, that was really fun, guys. Thank you so much for submitting these questions. If you have more questions, you can submit them in the comments and then I will answer them next time around. I'll be doing more of these live Q&As, so just keep an eye out for them. Again, you can comment your questions in the comments here. And if you have a thyroid nodule, if you have thyroid cancer, please contact us at thyroidcancer.com. I have a YouTube channel that you can see a lot of my interesting cases, and have a good rest of your weekend. Bye, guys.